Could you guys tell me if you can hear me? I'm using my cell phone as the phone and then my computer as the visual.
Yeah.
I can hear you. Wonderful. Thank y'all.
All right, well, we will go ahead and get started for the sake of time. We want to make sure we're timely. So we'll start out with a roll call. We want to welcome everybody to our AFM site initiation webinar. We have anybody from Stanford on? Anybody from Stanford? Can you guys hear me?
Yes.
Okay. Anybody from Rochester?
Yep, Mary Caserta.
All right, excellent. Anybody from Colorado?
Yep, Lisanna's here.
All right. Anybody from Vanderbilt? Anybody from Syracuse, State University of New York? Anybody from Rady's Children's? Anybody from Sick Kids, Toronto? Have anybody from South Florida? Anybody from Children's Research Institute? Have anybody from UCSF?
Yes, Charles Chu here.
Okay. Anybody that I did not get your name on that's on the call or on the webinar?
Yes, I just joined. My name is Juliana from Stanford University.
Juliana from Stanford?
Yes.
Okay, got it. Anybody else? All right, well, we'll redo this at the end just to make sure that if we don't have anybody that joins in the middle. We'll start with David.
Good afternoon and good morning, depending on where you are in the country. Greatly appreciate your time. Over the next couple of hours, we're going to be moving through the specifics of how to conduct the acute flaccid myelitis natural history protocol, and be able to actually document, to archive this recording of the afternoon presentation for sites that either were not able to join that were on the roll call just now, but also for additional sites that will be getting to the point of being able to be activated and be able to learn about the study that way, and be able then to be activated without having to wait for another one of these kinds of startup webinar types of approaches. So I'm going to be talking about what is called the DMID Protocol 190005, the AFM Natural History Study. See if I can advance this. No, it's not. There we go. All right, so the study objectives, really, I mean, the true reason to do this study is to create the biorepository of specimens. Associated with that will be the database that has both clinical presentation as well as outcome data for subjects that are enrolled on the study, as well as subjects enrolled without AFM who are in a matching family-related cohort that I'll explain to you more in a few minutes. The biorepository will be under a governance structure that will include the NIH, as well as members of the AFM work group that Carlos Pardo has been the leader of, and representatives as well who have kind of been newer to the game with the protocol team, who have been involved with protocol development. So there'll be a governance structure that will allow for competitive applications for access to these, what will end up being quite valuable specimens in the biorepository, and then the linkage, as I've said, with the database. There'll also be linkage to studies, imaging studies as well. The endpoints are listed underneath the overall, or I should say the objectives are listed under the overall objectives. Primary objective is to characterize the epidemiology and natural history over the first 12 months following enrollment. Secondary objectives are to describe diagnostic evaluations, to describe therapeutic interventions that are used in the clinical care of suspected AFM cases. They are not dictated or required by the study. The therapeutic interventions, for instance, are those that are deemed the appropriate thing to do at the clinical bedside, but as they are utilized, we will capture that information in the database. Another secondary objective is to identify risk factors for the development of AFM, to identify determinants of outcome of AFM, especially, a biomarker is the new buzzword for obvious reasons, to try to have a measure by which you can predict who's going to have what kind of outcome, because as we do have anti-enteroviral drugs or immune modulator drugs that are used systematically in future clinical trials, it would be good if we could have an outcome biomarker that could be used for endpoint description. And then finally, to describe the clinical characteristics of household contacts of subjects who are enrolled on this study with AFM. Now, I've sort of made allusion to this just now, as well as a moment ago, about the study populations. There are going to be two groups of participants in this study. Group one is the one, honestly, we're probably more interested in. These are patients who are presenting with either probable, possible, or proven acute flaccid myelitis. We're and they're enrolling in this so-called group one. Up to 350 such subjects are eligible for involvement. And as you'll see with the inclusion criteria, the inclusion are deliberately broader than what's used in the CDC case definition. This is an attempt to be able to sweep up subjects with potentially less severe disease and better be able to define that overall presentation and outcome that will be part of the reasons that we're doing this study. Secondly, there is a group two These are subjects who are household contacts of AFM cases. So contacts of subjects in group 1 of the protocol, up to 350 of them also will be enrolled. Now, looking specifically at the inclusion-exclusion criteria for group 1, of course, you got to have signed informed consent from the parent or legal guardian, as well as assent as appropriate, given the age of the patient, and that's determined by local IRB norms. Also, they have to have had acute onset of, I take that back, they have to have onset of flaccid limb weakness involving one or more extremities, suggestive of possible, probable, or confirmed AFM within the prior 30 days. MRI of the spinal cord either has to have been done or is going to be done clinically. It's not going to be required by the study. It's not going to be a study procedure, but we have to be able to know what the cord looks like in order for the neurology group to be able to classify a subject, as I'll talk about in a minute, with AFM proven or possible or probable. And so we've got to have access to that kind of imaging study. So that needs to either have already been done or going to be done. The age is under 18 years of age. These are minors, in other words. The weight is purely driven by the amount of blood out in the schedule of events that I'll show in a few slides. So there's nothing magical about being 7.8 kilograms other than that would give you enough weight to be able to have the amount of blood that we're going to take out for the study not exceed those norms that are dictated by the IRB as well as the NIH. Now, interestingly, compared with other studies, at least that I've been involved with, as an inclusion criteria for this study, the subject and family has to agree to future use of specimens. This is not an option. In other words, the whole purpose of the study, as I've said, is to build that biorepository, and therefore future use has to be something they're willing to agree to on the front end. The exclusion criteria are a known condition other than AFM causing the limb weakness, and then anything that you, the investigator or the investigative team, would deem might place the subject or the patient at unacceptable risk of injury, or that you judge them to not be likely to be able to fully complete the study and the endpoints of the study that we're and the visits of the study that we're aiming to accomplish. Now, for group 2, this is the group of household contacts. Again, signed informed consent and assent as indicated. Residing in the, they have to be a residing household contact of a child enrolled in group 1 and enrolled within the prior 30 days. So we've got to move relatively quickly in order to be able to enroll this group 2 subjects. There is not a limit to the number or age of the group 2 participants. Our preference is to have the subject be, or the group 2 subject be as close in age to the group 1 subject as possible. But if a family will simply not enroll, if they're, let's say their 4-year-old is the group 1 subject and they have a 5-year-old who's not affected with any limb weakness, if they simply will not enroll that 5-year-old, they don't want to have them stuck, for instance, or have a swab of the nose of that 5-year-old, yet a 17-year-old agrees to do it, then we'll take the 17-year-old. So, to the extent possible, get as close as you can to age of the group 1 subject, but it's not written in the protocol that it has to be a certain relationship other than living in the house, being a household contact with that child. And as is the case with group 1 subjects, as I've already kind of alluded to, they have to agree to future use of specimens. Exclusion criteria, if they have flaccid limb weakness, that would actually put them in for group 1 instead of group 2. And then any condition, as was the with the group 1 exclusion criteria, anything you think would place the subject at risk. Now, the group 1 population is described on this, this particular slide. When a subject enrolls on group 1, Information will be gathered on them. Imaging data and clinical data and laboratory data will be gathered. That group will then be assessed by an adjudication committee, and the adjudication committee will classify them as being either Group 1A or Group 1B. Group 1A are those that, following the adjudication committee's judgment, have possible, probable, or confirmed AFM. Group 1B are those that do not have AFM. Maybe they ruled in another disease, for instance, or they had no imaging abnormalities of the cord, that kind of thing. Based upon data we have received from CDC, we estimate now, and of course this is a guess, but we estimate that 70% of those subjects enrolled in Group 1 will go ahead and be classified as 1A subjects, and about 30% that enter Group 1 will be classified ultimately as having non-AFM, being a non-AFM case, and be grouped as Group 1B. It's anticipated that this meeting that will have enough information in our database and accessible to adjudication committee members so that within 3 to 6 months after enrollment in Group 1, they'll be able to sit down and go through and make the kind of judgment as to whether it's a 1A subject or a 1B subject. The adjudication committee is membership and processes are in the lower half of this slide. It will consist of 2 standing members. These will be neurologists and members of the protocol committee, and they will review the select data for a given subject. When they're in agreement, when they both agree, that subject will be either what they agree on as a Group 1A or a Group 1B. However, if one thinks it's a 1A and the other thinks it's a 1B, then a third neurologist from the protocol committee will be recruited in to provide additional review, and as needed, other experts like neuroradiologists or others can be brought in as well, such that consensus ultimately can be reached as to whether a Group 1 subject is a 1A subject or a 1B subject. Now, I hope your screen is a big screen on your computer, because this is the schedule of events for Group 1. And I'm going to spend just a minute kind of going through this because I think it's important as we kind of think through. This is the meat, in my view, this is the meat of any protocol, is going straight to the schedule of events and the footnotes. This tells you what it is we're doing, and then the rest of the protocol kind of fleshes it out and describes it in greater detail. One thing I'd like to point out along the top 2 rows, initially we frame things in terms of study day, and then subsequently, as we get farther out, we frame it in terms of study month, and those are defined in the protocol. Screening informed consent is and the other thing I want to mention about that is the windows. If you look at the windows, all the windows abut another window. So, if you have a situation where the subject is harder to get back into clinic, for instance, whenever you can get them, by setting it up this way, whenever you get them to see you in clinic, they will fall within a study window. It may not be the ideal one that we want, but it will be able to capture data in the database from them as a consequence of that. So to begin with, on study day 1, screening informed consent, screening and informed consent will be conducted, and the informed consent will be signed. Baseline demographics and patient history will be obtained. Any kind of neurologic illness assessment in household members also will be obtained and recorded in the database. Of those, there also will be a detailed patient history around month 3, at the month 3 visit, which is plus minus 2 months following month 3. Neurologic examination will be performed on days 1, 3, 7, 28, basically each of these visits, month 3, month 7, month 12. What's listed on this particular schedule of events in yellow font are things that are not required by the protocol. Now, in a way, MRI sort of is required by the protocol, because they have to either have had it, or MRI of the spine, or going to have it for clinical reasons. So in a way, maybe you could argue that should not be yellow font, but I wanted to draw it out, as I've already mentioned, with the inclusion criteria, and therefore left it in yellow font accordingly. And so any additional MRI findings, MRI testing that is done will be captured in the database if performed during the first 12 months while the study is being conducted. Now, there will also be nasopharyngeal specimens obtained. Those will be obtained on day 1 and on day 3. And then oropharyngeal specimens on the same, day 1 and day 3. Blood will be obtained on days 1, 7, 28, and month 7. And then of that blood obtained, there'll be separation out of PBMCs and plasma. There also will be serum, and there will be whole blood. And Jill will tell you more about that when we go through the MOP, the Manual of Procedures. Stool also will be obtained, and that will be obtained anytime over that first week of following enrollment on the study. CSF fluid for the biorepository, I guess in a way that there's two different lines here, but the CSF, if obtained for clinical reasons, the residual sample will be swept up and put in the sent to the biorepository, and then indices as well will be recorded. And that's throughout the 12 months. Whenever they have an LP, and I'll have a little bit more information in a minute about what volume of CSF we're going to recommend be obtained. But of course, since it's not covered by the protocol, it's not required by the protocol that those volumes be obtained. Subsequent hospitalizations and medical diagnoses will be recorded at each of the follow-up visits, not the day 1 visit, but the days 3, 7, 28, and you can see on out through month 12. Also, any results of a virologic or immunologic workup will be recorded on day 28. So if they've ruled in for an autoimmune reason, that would be recorded in the database accordingly. Targeted con-meds will be recorded at each of the visits. There'll be a baseline group of meds, and then the con-meds thereafter recorded across the time periods. And then any kind of therapeutic procedures will be recorded on, about day 28 in the subsequent months. If there is nerve conduction studies or electromyography that's conducted on the study subject, those results will be recorded. And assessments of the degree of neurologic sequelae also will be recorded. We have a panel of different types of tests that will be obtained. We are greatly appreciative of our neurology colleagues and collaborators and of the PM&R group as well that was part of the protocol committee to identify what of those should be obtained. Now, the following slide I'm not going to go through, but these are the footnotes to the schedule of events. These are in the version of the protocol, the PDF of the protocol that you have. I tell you, I think there may be some noise, so if y'all could mute your end, that might make it's okay from our end, but it might be hard for others that are on the whatever this is, webinar, yeah, but it's a Zoom, right? Zoom webinar to be able to hear. Thank you, I appreciate that. And what you can see here is simply that I highlighted in yellow again, those that are not required by the protocol, and this is spelled out in font you can actually read on this slide. Studies not dictated by the protocol: lumbar puncture, MRI, EMG, NCS, with the exception of MRI, which is required for inclusion in Group 1. Results of residual specimens from those studies, though, will be swept up, and if they have been performed for clinical reasons, will be swept up into the database and hopefully into the biorepository if there's specimen residual as well. Now, let me mention a little bit more about CSF. When lumbar puncture is being performed for clinical purposes, the parent or the guardian will have the option to agree to the collection of additional CSF beyond that needed for clinical purposes. This was something Roberta DiBiase suggested, and it was embraced by the protocol committee. Those total volumes will not exceed what I'm going to show you on the next slide, and that's based upon a number of international organizations' guidelines and documentation of the safe volume of CSF that can be obtained at a given time. And it's illustrated in this particular slide. And you can see for a term neonate, up to 4 mLs can be taken out with a given LP safely. For an infant, it's 9 mLs, young child 12 mLs, adolescent 15 mLs. So the parent will be given the option of saying, yeah, you got a needle in my child's back, feel free, and you're going to take 2 mLs for the study, that it's a young child, feel free to take an additional 10 mLs and be able to safely do so, but also have that additional 10 mLs available for future study of acute flaccid myelitis. This is the schedule of events for the group 2 subjects, and they are as follows. The windows, again, abut one another. There's obviously many fewer windows, and we follow them out for 28 days. Screening, informed consent, baseline demographics, detailed patient history, those are all done on day 1. Neurologic exam on day 1 and with any kind of unscheduled sick visit. Nasopharyngeal specimens and oropharyngeal specimens obtained on days 1, 7, and 28. Blood on day 1 and 28, and again, it's the same separation out for PBMCs and plasma, for a serum, and then a sample as well for whole blood. Stool during the first 7 days, but also at day 28 and with any unscheduled sick visit. Neurologic assessment on day 1, that's to make sure they don't have any kind of limb weakness. And then a record of the interval illness and final diagnosis will be taken on day 28. This is shown in terms of footnotes on this slide. And again, you have those with version 1.0 of the protocol that has been distributed to you in a way that, I guess these are a little bit easier to read, but than the group 1, because there are fewer of them. But you have that more readily available and easy to access in the protocol. Now, the final thing I want to mention is, and then we'll open it up for questions, but it's this unique partnership for this particular study between the CDC and the NIH. And this has been a part of it from the very beginning. I know many of the AFM work group members, again, the group that's led by Carlos, had already been working with CDC for a long time on acute flaccid myelitis, and had a good solid working relationship with the CDC. NIH, when they came in, when NIAID came in, wanting to put money behind this, what ultimately became this research study, they also wanted to maintain that harmony and harmonization with what the CDC is doing. And so for that reason, there will be something that Jill, I think, will go through about how the study coordinator at a given site will interface with the public health officials in that community, in that locale, who in turn will be in communication with the CDC. Rather than have a given, and CDC obviously through its public health mandate has a responsibility to go in and get samples as possible from patients with acute flaccid myelitis and other diseases too, but as it relates to this, acute flaccid myelitis. So what we seek to do is to not complicate the communication with the family by having the public health people doing it on the one hand and the research team doing it on the other hand. Rather have it all be able to channel through it, at least initially, the coordinator and the research team obtaining consent, and then of the specimens that were in the schedule of events we just went through, providing aliquots from the respiratory tract samples, from the blood samples, from the spinal fluid if it's obtained for clinical reasons, from the stool samples in group 1, providing aliquots of those to the CDC. Now, it's a bit of a complicated way that it gets back to the CDC, and we have an even more complicated system by which, without using names, we can link what is received and run at CDC with ultimately what's received and stored, and also data captured from the research side from the protocol and the biorepository and the database. So there will be linkage, albeit de-identified linkage, between the two. Now, the CDC specimens will not be part of the research protocol or the biorepository, but as I've said, you know, if they run EVD68 on it at the CDC lab or immunologic studies, those will be able to link back to the database, the research database, and we'll be able to capture that. Those are my slides. It's a relatively brief overview. I'll tell you, when I've been involved on the receiving end of these kinds of startup meetings, you know, to go through line by line of the protocol, I have found to be less meaningful because, you know, it'll be months before I actually see a research subject and I pick the protocol back up and quickly relearn it. And for that reason, I have not, you know, taken a real deep dive. I've tried to keep this more, you know, kind of mid-level review. But I'm open to any questions. I'm going to stop talking now and see if you all have any comments or questions for this part of the presentation.
David, it's Mary Caserta from Rochester.
Hey, Mary.
One quick question that might is probably in the footnotes, and I haven't read them, but in terms of having a neurologist do the examinations, would it be possible to have a neurology fellow, a child neurology fellow on this protocol?
Yes. Yeah, definitely so.
And David, this
And
is
actually-
Bonnie Maldonado. Can I add to that question? We talked to Keith Van Haren here at Stanford, and he told me that he thinks, in his opinion, it would be possible to train us and PEDS ID to do the neuro exam so that we could do it ourselves. But it's not clear to me what the neuro exam entails. So when you look at some of the detail, there's some small tests, that dexterity tests, et cetera, that are typically performed here by physical therapy, but those count as neurologic tests. So we were going to get some clarification on that, but also wondered if it's possible if the neurologist signed off on us doing the neuro exam for some of these kids, that might actually expedite the process for the kids, but also would be less expensive than having the neurologist involved as well. I don't know if that's a possibility.
It definitely is. So again, the footnote's too small to read on the slide, but footnote F is what F is in Frank is what relates to this. So this is a neurologic exam to be performed by neurologist or trained clinician, e.g., such as rehabilitation specialist, including Medical Research Council scale. So it's a MRC scale is part of the exam. But in terms of who can do it, neurologist or trained clinician. It doesn't even say physician, it says clinician. And it does say such as rehab specialist, but it's not limited to rehab specialists. So Bonnie, I think that hopefully, Mary, that answers your question as well. And Bonnie, I think that if your group feels that they can adequately sign y'all and sign y'all off and check you off for being able to do that, then that certainly is a reasonable thing to do.
Thanks very much.
Other questions or comments? All right, I'm going to turn it over to Jill, and she's going to go through some of the more granular aspects of this, the kind of how-to from the manual of procedures and other documents.
All right, thank you, David. David mentioned we're not going to go detail for detail. And as David mentioned, that we can get you guys to mute your line. We're getting some feedback on our end. So if you don't mind muting your phone, that would be great. So I'm going to go high level. I'm not going to go detailed because, again, we did send out the manual of procedures to everyone, so you guys have the full detail on how this study will be conducted. So the areas that I am going to go over.
Let me just, yeah.
Hello, if we can get everybody to mute their line. We've got a conversation going on in the background. Can we get you to mute your line? Okay. So like I said, these are the things, areas that we're going to go over here that I'm going to go through as a review with you guys. Thankfully, David has hit a lot of mine, so I think my slide set will be pretty quick. All right. So with regard to screening and enrollment, we are going to be capturing pre-screen failures as well as screen failures. So I wanted to describe what the difference of the two. Your pre-screen failures are going to be any subjects that did not sign their consent form. So basically, if you've gotten permission from your IRB to do a review and you determine that the subject did not meet inclusion criteria, then what you want to do is you're going to capture just basically a combination of numbers of how many of those subjects were not eligible. We're still getting a little bit of feedback on our line. So again, if you guys can mute your phones, that would be great. Screen failures are going to be any of those subjects that signed a consent form and then withdrew prior to any type of assignment. They've been assigned in the EDS system, but still they decided they didn't want to participate before any procedures were done. Each month, the sites will capture the total number of subjects that declined participation and the reasons why those subjects did decline. That information will be entered into our electronic data entry system on a monthly basis at least. Your enrollment will be occurring through the EDS system. This is a password protected system that we're going to go over with you in more detail at the very end of this presentation. We do require at least one person from each site to have EDS access at all times. As David has already alluded to, this is a written schedule both for group 1 and group 2. I've just got them outlined here side by side. And as you recall, group 1 is your AFM patient, and group 2 is your household comparators, your contact. Your study assessments for group 1, David again already kind of alluded to some of these. I hate to mention it again, but I still got somebody that's got the open, and now we've got papers rambling. So if you can mute your lines, that would be helpful. Thank you. All right, so we've got demographics. We're going to include the home address, the school, and the daycare. We've got your detailed patient history, which does include your any kind of proceeding, respiratory, GI, seizure, fever, rash, over-the-counter, prescriptions, vaccines, IM injections, surgeries, trauma, travel, social history for the subject. Also, you're going to include in that detail.
Oh, you didn't have to, honey. If you needed them, you could have kept them.
Household history, respiratory,
Take care.
GI, fever, rash.
Hey guys, I can hear conversations going on.
Can you ask if she's going to be available? Do you guys have a
Take about 2 seconds and you.
It's right now, forever.
I will check. I'll let you know. I'll have her email.
Please.
20th February?
Yeah. Because I'm going to.
All right.
Your other side.
Yep. Oh.
Thank you.
Can we get everybody to mute their lines, please? We've got feedback. We've got a conversation going on in the background that's overriding our presentation. Okay, so like I said, we've got the neurologic exam that's going to be done on the days listed here. It does include the EMG and the nerve conduction studies done for clinical care. Those results will be captured. Again, a copy of the de-identified report along with the raw data, the traces, and the graphs. I will get a copy. You're going to email a copy of those to me here at the central unit. With regards to your MRI results, if done for clinical care, a copy of the de-identified images on a DICON CD will be mailed. You will make sure you get the PID number included on that CD on those images. Those will be mailed to the UAB unit for storage in our image repository. We've got a nasopharyngeal swab that will be done on days 1 and 3. You want to make sure you measure from the tip of the nose to the ear to make sure that you're getting an NP swab and not something else. You've also got an OP swab that'll be done on days 1 and 3, and that's going to be collected from the posterior pharynx and tonsillar area of your patient. Blood will be whole blood, serum, plasma. If your site has capabilities to do PBMCs, you've got PBMC collections as well. Who's gonna do something to it and I won't move. I'm trying to advance our slides here.
This patient says they're in one of your studies, but there's no shots in there. But it says they got them all on this day. They did.
Okay. We'll also collect stool samples. You have samples on 2 different days, anytime from study day 1 until study day 7. If by study day 5, the subject has not had a bowel movement, you can do a rectal swab. So you're going to do 2 swabs on 2 different days. As David has already mentioned, if they're having CSF done for clinical care, you're going to collect any of the residual samples. If you happen to be present during the procedure, you are going to collect a fresh sample, and then the results of any sample that was done for clinical care will be recorded in the database. Also, as David mentioned, we're going to be sending some samples to the CDC for their public health surveillance. And these are the samples that you're going to be sending: 1 aliquot of serum, 1 aliquot of stool, 1 aliquot of CSF, your OP, and your NP swab. And you'll be working through your hospital clinical staff. You'll route those through them, and the hospital clinical staff will then forward those to the local health department. The one thing that will happen is the results of those CDC lab results will come back to the person that reported those. So around month 3, the coordinator would need to get in touch either with if it's not uploaded into the medical record, get in contact with that clinical staff, get results of those lab results, and then enter that information into the EDS. You do want to make sure that you include the CDC specimen ID numbers for every subject specimen that's entered. These are the neurologic sequela testing that's going to be done. These can be done by a coordinator. It can be done by a physical therapist. It can be done by, OT, anybody of that nature. So you're going to have your physical abilities and mobility scale. It's basically a questionnaire. You're going to have your 9-hole peg testing for those greater than equal to 3 years of age. You're going to have your 2-minute walk test for those greater than equal to 3 years of age. You're going to have your promise, which is actually what the subjects greater than 8-year-old will fill out. You're going to have the promise proxy, which is filled out by parent for all subjects. And these should be tested as early in the window as possible. You can complete these over multiple days if needed. Also, David already alluded to this, you're going to be capturing any kind of virologic and immunologic results that were done anytime between days, study day 1 and 28. And that data will be captured in the EDS. Any subsequent hospitalizations or diagnoses, you're going to also capture that in the EDS. Your targeted meds, we're only going to be looking for those meds like the IVIG, the Maranon, the steroids, antivirals, plasmapheresis, PT, and surgery. For your group 2, you're going to still do that same demographic. You're going to do the same detailed patient history. They will have a neurologic exam on day 1. And if they have a sick visit, they'll have a neurologic exam. If that sick visit includes some kind of neurologic symptom, they'll have NP and OP swabs just like your group 1. They'll also have blood, PBMCs if your site has the capabilities to do that. Stool, I do want to make a correction on this slide. It should also include day 28 as well. So 2 samples collected in time from day 1 through 7, also at day 28, and then at an unscheduled sick visit. For the neurologic assessments for this group, you're only going to be doing the promise for the children greater than 8, and then the promise proxy, which is a parent assessment done for all kids. You're going to be doing internal illnesses and final diagnosis, so recording any kind of medical diagnosis, hospitalizations that they have from enrollment through study day 28. And if your subject develops any type of respiratory, GI, or neurologic symptoms during the 28-day follow-up, you will bring them back, collect an NP, OP, stool, and perform a neurologic exam if they have neurologic symptoms. We do ask that you adhere to the protocol and the MOP. Of course, if there is any type of protocol deviations, that should be reported within 5 working days of you being notified or made aware of it. If it increases patient safety, then it should be within 1 working day. And then protocol deviations reported to your IRB or your IRB guidelines. Any questions for me? Any questions regarding the clinical operations side of it?
Jill?
Yes.
Jill, this is Sarah Hinton. Can you mute it from your end? Because it's really hard to hear you.
I am so sorry. We've been trying to do that.
Somebody's on that's not paying attention.
Yes, unfortunately.
You need to mute.
We've tried to
figure out a way
to mute everybody, but we can't. We don't have that capability on our end. Yeah, I do apologize for that. Like I said, somebody's definitely not paying attention to the muting. All right. Any questions from me? All right. Our next section is going to be our lab supplies, our laboratory.
We're going to try something because of the audience, the difference, the noise in the background. And this is our first Zoom conference call, so we do apologize. So we're going to try to mute all the attendees so that you don't hear that background noise. So just give us just a few minutes right here to go into that. Manage participant, mute all. Yes. Yeah. Okay. I guess we don't know. Sarah, if you were on the call, would you send me an email letting me know that you are still being able to hear my conversation? If you're still there, Sarah, please, from one of our sites out there, please send me an email. Let me know that you can hear us, because I was able to successfully. Right. And so you should be hearing me now. And if not, go back and unmute yourself. Go back and go to you.
I'm already unmuted.
Okay. You should be unmuted.
Well, let's do this. Let's unmute all. I asked the question. Sarah, when we just a minute ago, we unmuted everybody. Were you hearing that background noise?
We can hear you when you mute us.
Okay, you still heard us, but the noise.
Yeah, we can hear you. I can hear you.
Perfect. So we're gonna go ahead and mute everybody back again, okay? Okay. All right, Jennifer.
Hi, everybody. This is Jennifer from the Central Unit Laboratory, and I'm just going to go over very quickly kind of what your study supplies are going to basically look like. I think most everybody is aware, excuse me, of what the supplies you're going to need, but here we go. So for your nasopharyngeal and your oropharyngeal, you're going to get a flock swab and a viral transport media, which comes in a little packet together as shown in this photo. And okay, yeah. So an alternate to a nasopharyngeal, if you cannot get a nasopharyngeal swab for any reason, you would be doing a nasal wash according to the MOP. So for that, you're going to be getting a sterile cup, lactated ringers or saline, a nasal syringe, and this minimum essential media. And all of the procedure for that is detailed in the MOP. So this is only for alternative. For your serum, it's just going to be a regular SST tube. For the whole blood, you're going to be collecting the PAX gene DNA tube, which is the blue tube shown here. And you're going to be collecting a PAX gene RNA tube, which is the red tube. And if, for for any reason, if the packed gene RNA tube is the only tube collected at the time, you will be collecting a discard tube before collecting the packed gene RNA tube. For your PBMCs that you're going to do only if your site has the capabilities, we will only be supplying the cell preparation tubes, and we will not supply these other items listed here, which will also be in your MOP. For stool, you're going to get the stool collection hat, as we're calling it, and a clean, sterile screw top tube. It's going to look something like this. The tube may change depending on what we finalize for the ability to get the poop in the tube. And as Jill spoke about the alternative to a stool, if the participant has not had a bowel movement in a certain amount of time, you're going to use a rectal swab, and that's going to be the same type of thing as the flock swab and the viral transport media that you're using for the NP and the OP. And for the CSF, if you are retrieving residual sample from the laboratory, you're just going to aliquot into these the smaller cryovials, and if you do happen to be present when a fresh sample is being collected, we're going to have larger tubes for that, and then you'll subsequently aliquot those into the smaller tubes as well. So we try to provide all our supplies in a nice handy kit that will be labeled for each specific collection period. And most of the coordinators that have worked with us before know the kind of how those look, and they tell me that they're easier to just grab a particular day, pack it, and then go collect the samples. So we're going to do that. We're going to also provide sample labels, and I believe it's in the MOP as to how each sample aliquot will be numbered. So each individual aliquot will have its own individual number. So if you have 3 aliquots for CSF, for example, you're going to have the PID number -001, 002, and 003, and so forth. We'll also be supplying the insulated shippers for transporting the samples to the lab once you have collected everything on a subject. We'll be providing cardboard tube boxes for the storage and shipment of the aliquots, and we'll provide FedEx air bills that are pre-printed with our address on it. But in case you do not have any of those, our shipping address is here. And that's basically it for the laboratory. Does anybody have any questions about that? Let me unmute you. Hang on a second. All right. Where do we do that? Thank you. I think it's over here and more. Manage. All right. Manage participants. Yeah, click right there. And then unmute all. Okay. Okay. Does anybody have any questions? You're all unmuted right now. Okay, we're going to move on to Susan and regulatory. Thank you.
Okay, good afternoon, everyone. My name is Susan Branscombe. I'm the regulatory administrator here at the UAB Central Unit, and now you can't talk to me because we've muted you all. Yay. So here we go. I'm going to go over some of the regulatory documents. This is probably the hardest time. This is probably one of the most unpleasant jobs to have, but we've got to get through all these regulatory documents and get them in place before we can activate your sites for these studies. So here we go. So what I'm going to do today is provide you with the guidelines for why we need the regulatory documents, and I'm going to discuss in a condensed version of the regulatory documents that we need from you in order to activate your site for the study. So here's why we need what we need, and here's the guidelines for it, and this is why you have to maintain one file for each site, and then they got to be started at the beginning and updated throughout the life of the study. So right now we're just really going to concentrate on the documents that are needed at the beginning of your study. So first of all, I want to say, have you submitted your site contact sheet yet? If you haven't submitted your site contact sheet yet, please do so, because we have to have who all's participating in your study at your site so that we can keep everybody informed when we submit out all of our emails and things like that. So if we don't know from you who's going to be in the study, please help us keep you updated. We broke this down, and everybody should have already received the emails from me at this point, from the UAB Central Unit. You should have received the protocol, the informed consents, these checklists for site-specific and protocol-specific documents, and all of the informed consents, and every study document that we need from you. You should have, that's already been identified. You should have received that from the Central Unit at this point. If you do not know or don't know what I'm talking about, or have not received any of these documents, please shoot me an email at the end of this call, and I'll be glad to get you up to date on all the emails that's already been distributed. Then we've broken it down to protocol-specific documents and site-specific documents. These checklists have already been sent to your sites. For those of you that have been proactive during this activation process and have already submitted your consent forms back and forth, you should have received from me a detailed list itemizing line by line what documents that I still need from your site before we can activate your site for the study. If you have not received that from me, that means you haven't sent me that many documents. Okay, so if you would go ahead and start sending those documents in from me, and then I can start consolidating them and letting you know what else is needed. Please do not wait until you get all of them. I'll take one at a time. If you want to send me one document each day, I'll take one document each day. So I'll take it as you can send it to me. Most important document that I can get from you at this time, without the informed consents, of course, but if you could submit me that contact sheet and also your IOR. The study IOR is an investigator of record, which is for a non-IND study. And if you would submit that IOR to me, which is the equivalency of what take place of the 1572 that you're familiar with, then from that base document, I can kind of know a little bit about what's going to go on at your study and what to be expecting. And the good news, and this is what it looks like, this is the IOR for the study. The good news for this study is I'm not going to be collecting CLIA, CAP, and reference ranges from you. And we will not, and let's see, the one thing that we will need, yes, our IRB will be on there because this is going to be a single IRB review. We will need your IRB on it. And I'm going to talk about the IRBs in another slide here in just a second. But this right here, this thing right here can tell me where you're going to be doing the study, who's going to be doing the study, and who the sub-investigators are going to be. And then what I can do for all of you sites that have already participated as in the past, I will be happy to pull the CV, medical license, HSP, GCP training from all of the participants that have done previous studies from us, and I will bring those forward from those. But I won't know who they are until I receive this document from you. But I'll be happy to help you fill in those blanks with that. All right, going on to the next one. We're talking about the single IRB, and I'm going to keep this real simple because I know that this is the first time actually that we have in the central unit used a single IRB. I'm not going to say I love it, but I'm going to say this is the first time that we've used it. And so we're all going through a lot of headaches with it, and we'll go through a lot of, we'll be real patient with each other and go through this together. But all your IRBs at this point would have received a notification from our IRB via the Smart IRB, their website, for reliance on us, the UAB Central Unit for the study. And this is what it looks like. So when you go into the Smart IRB and the request for reliance, you can see that UAB, I don't know if you can see, yeah, you can see that UAB has submitted this. And so far, of all the 38 sites, there's an exception of 6 sites that we knew because of the UK, because of the Peru site, our Canadian sites, and a couple of others that we know were not willing to reply. But of the 38 sites? Of the 38 sites that we have here, we had about 32 sites that were going to are willing to rely. But so far, we've only had 9 IRBs go in and say that they are willing to rely. And these are the sites right here that are already willing to rely. With that being said, I'm going to say this. your IRB, your local IRB will have their own local requirements that they require from you to be able to rely on an outside institution. So what we're asking your IRBs is to rely on the UAB IRB as the IRB of record, if you will. And so you don't have to know these terminologies. Just know that your IRB will ask you, if you want us to rely on UAB, then we have a packet that you need to submit to us. It's going to be a little different than what you usually submit on a regular routine IRB at your site for your submissions. So that's in a nutshell of that. The next thing that we do, and the most single important document that's going to keep us going forward, is that informed consent. And when I say informed consent here, I'm talking 4 of them. We've got 2 consent forms, one for group 1, one for group 2, 2 assent forms, one for group 1 and one for group 2. So we have already provided you at this point with a template. And we've identified only those areas of the sponsor's informed consents that you are allowed to modify and make changes to be a part of the single IRB process. You take that consent form, you make the changes to it, and here it is. We got to go through all this cycle right here before we get it back to you. So first thing that we want you to do is we want you to send it to the UAB IRB for review. And I see that that's not you can't see that, can you? And then number 2 is when I say send to the UAB IRB for review, that's going to be Jill, the central unit. Oh, I'm sorry. You're going to send that consent form to the UAB central unit, Jill Griffin. You're going to send it to Jill, and Jill's going to review it. And she's going to make sure that you've done just what we've asked you to do. And in addition to that, because we don't know what your local IRB language is, there's a local IRB language content that we've already provided to you. You're going to take that local IRB content information and get that completed by you and your IRB will complete that together. When we receive your consent forms back and that local content back, then Jill will review your consent forms to make sure that it's in compliance with what we've asked and it's in compliance with what your institution has asked, and then she's going to review it and make changes to it or not, and then get back with you. But she makes the changes like right on the document for you, and all you have to do is review and accept it. It's not a complicated process. She actually goes in and makes those changes for you, and then asks you to look at it, see what changes that she's done, and then you accept those changes. When you accept those changes and everything's final between you and Jill, then I need a copy of it back. Once I get a copy of it back, I being the UAB Central Unit Regulatory, once I get those consent forms back, I take those consent forms and your local content information form, and I will submit that to our UAB IRB. Then they will review it. It goes before an expedited type review that goes before, and then they will stamp and put the UAB IRB stamp on it. They will send it back to me, and then I will in turn send it back to you. So yes, that's a cycle. So that's where our time constraint has been right here, is in this cycle right here. So hold your questions. I know you have some questions right now, so hold them till when I unmute you at the end of it, that we'll get back to and answer those questions for you, okay? So we're gonna quickly go past this now. And we're gonna go back to the IOR that I was talking about earlier. And when you put your CV and when you put your PI on there and you put your sub-investigators on there, know that when you do that, immediately I'm going to need these 4 documents. I'm going to need you to send me their CV, current within 5 years, signed and dated if you would, please. Not a requirement, but I do like to see it signed and dated. That way at least I know what the current year is. And on their medical license, and here's the catch, their initial HSP training. I don't want the one that was just taken last week or last month. I want the one that they did the first time they took their initial HSP training. And I know that's kind of strange, and everybody asks me, well, why do you want that one? Because we want to show that you've had that one, because your continuing IRB training is contingent upon each individual's institutions, and that's up to how each individual institution wants to maintain that. So we just want to know that you've had that initial training. GCP training is another document, is another training altogether, and that's another animal. We want that, and we also want it updated every 3 years. So we don't want the initial GCP. We just want to see that you have a current GCP training certificate within the past 3 years. Okay. Now then, the required training for this study. The required training for this study is going to be GCP and HSP, and that's everybody. If you are on the study team, you got to have GCP and HSP training. I only collect, the central unit only collects the GCP and the HSP training for those individuals listed on the IOR. But if this study is going to be monitored, then the monitor will come out to your site and they will review your site responsibility signature log, and they will review it to make sure that everybody is qualified by training to do the assignment that to do the job that they've been assigned to do for the study. GCP and HSP means that you've got to have that with your name just being on that sheet of paper. If you are going to be doing the source doc and the regulatory documents, then you'll have to have those training. And if you're going to be doing the electronic data entry, then you'll have to have the EDS training. And those are all free. They don't cost anything. They're all free. And we do have links that we can provide to you if you need them. Okay. And we'll come back to that. So that's not a lot of required training right there for this, because there could be a lot of others, but this is all that we're requiring for the study. And like Jill mentioned earlier, all the other ancillary tests and things like that, you have to do the 9-hole peg test and the other different tests, the gate testing and all GANT testing. That's all not, there's not a formal required training that you have to have for that. That's just going to be a part of your, right, Jill?
That's correct. There's no formal training for those.
Okay. All right. So there we go. So there's all our required training. And don't worry, we are going to send everybody a copy of these, this presentation. We'll send everybody a copy of this for your file of the whole presentation that we've been doing today. Okay. I am going to throw Eyelet under the bus. I told her that I was going to throw her under the bus because she's not prepared for this, but she is our clinical quality management plan manager for the central unit. And the clinical quality management plan is a required regulatory document that's required before we can activate your site for the study, but it is an entire process on its own. So I just wanted to let you know that if you haven't already been in contact with Eyelet, that you need to be in contact. And I always try to include Eyelet on the emails. When you get this far in your regulatory documents and I say, I need your CQMP, I always try to put on there, please contact Eyelet Dale and her email address. And then at that point, then I'll include Eyelet in that email so that she can kind of come in the loop with us too. And I'm going to look at Eyelet and see if she's looking at me real mean. If she's not, maybe she might wants to say something to us. So Eyelet, do you have anything that you would like to say about their CQMP?
This is Eyelet. Thank you, Susan. Just to let you know that this process is not something that's really difficult, because the DMID has provided us with templates that's very helpful with instructions on how to complete a CQMP. You may already have one at your institution. And if you already have one at your institution, send me a copy and we'll look at it. And if that's sufficient, then you won't have to create another one. We would use that one. But just send me an email and let me know when you're ready to receive those documents.
Thank you, Eyelet. And she wasn't looking at me mean, so we're still friends. Okay, so let's go on to the next one. So once we get all these regulatory documents in place, and it's a lot of them, but I'm going to work with you. Please, I will work with you. I will do whatever I can. If I have corrections that I need to have corrected on an IOR or something, I will 9 times out of 10 correct that IOR or any document that I need and retype it and send it back to you. I try to make this process as easy as I can for you. And I do appreciate your time and your patience on this, but this is the gold star. This is what you want. Once you receive this activation letter, then you're cleared to go and begin your screening and enrollment for the study. So this is what you need. Once you get this letter, and only once you get this letter, then can you start screening and enrollment for the study. All right, so now, what can I start sending in now? Hey, Susan, what do you need? What can I start sending in now to you? Like I was talking about, if you haven't already done so, send me whatever, send me your ICS, send Jill your informed consents for review. and work back and forth with Jill on that, and she will get your informed consents back and forth. Why we want you to send it to Jill first is we just want to help. We just want to make sure that there's not going to be a lot of back and forth between your IRBs and you. So that way, if we can look at it first before you send it to your IRB, we're just trying to help. That's the only reason that we put ourselves in between that. Send me that IOR. Please send us the contact sheet so that anybody doesn't get left out on important information. And any other regulatory documents, CVs, medical license, or anything like that that you want to shoot to me, please send them on over. Okay, today's training is very vital to your startup meeting. Please make sure that you document today's site initiation visit. And you're going to document this on your training log. But you're going to say, but Susan, I don't have a training log yet. And you're right, we have not sent out the project notebooks. I will send you this training log after our conference call today. And so if you would, please document this site initiation visit today. We have been given permission from DMID that if your PIs were not able to attend this training today, that they can do this training by listening to the audio video conference that we're doing right now. They'll be able to listen to this, and in the type of training they can just put reviewed recording or something like that. So this by the mode of training. So document the training today on your protocol other training log, which you don't have, but I will send to you today. If anybody has any questions, now I'm going to unmute everybody, and I'm going to let you ask any questions that you want. And I was going to say that I'm going to answer them, but I'll let you ask them. Okay, now you're unmuted. Does anybody have any questions for the regulatory?
Okay, so hearing none, I'm going to go ahead and mute everybody back, and we'll do the subcontract and import.
Good afternoon. I'm Mary Wyatt Bowers. I will be handling subcontracts, budgets, invoicing, and working with your Office of Sponsored Programs. I've been here working in the CSG for a number of years, but I'm pleased to report that we have Sarah Dowdy, who is in pediatric neurology, who is also joining us to help with this study. I know most of you who are doing that subcontracts and in the neurological area are working with Sarah on those. She wasn't able to be here today. She's actually helping with the patient appointment, but she will be working with many of you on your subcontracts. Those of you that have worked on previous studies have probably seen this picture because, as always, with any federal study, it's a push and pull with the money. We try to provide the sites as much as we can, both for your effort in setting up and running the studies and for the patient enrollments. But with all of our studies, we have limited budgets. So we try to get you as much as you can, and we will do that throughout the study and modify it if we need to. Since this study is set up under two different types of awards, I'm going to talk about agreements. We will have some with subcontracts and some with subawards, but with regard to the regulatory and administrative setup, they're similar, and the protocol itself is the same, so you'll be following everything the same whether you're a subaward or sub-agreement. We're providing sites with the initial startup funding that we have in invoices milestones, so we do expect, particularly for the subcontracts, that there's some effort expended because NIH requires that we show effort when we provide payment for the studies. We've sent most of these agreements, whether they're subcontracts or subawards, to all the site. There are a few that have forms that are still outstanding. These relate to the risk assessments that NIH requires now and contact information. We know some are reviewing it for feasibility and budget and that kind of thing, but anything you can do on your end to speed this up will help us to get these all in place for everyone. We're about, I think, 50% now on getting some of the subcontracts done. So we're in better shape than we were, but we need your help to get these processed. So if you have not had anyone contact me from your sponsored programs, or if you have any questions about the subawards or sub-agreements, please contact me or Sarah Dowdy. The invoice requirements are typically 30 to 45 days from month end of a quarter. I realize based on experience that that's difficult for some sites, but the important thing is to get the invoices in on a regular basis, because with this funding, NIH either ends it at the end of the year or they'll pull back funding early if we're not spending it. So we encourage you to get them in as early as possible, at least quarterly, depending on what your institutional agreement is. And all of the invoices have to include this information that's on here: the date, the current cost, and the statement that's signed by someone from your institution, saying that you're agreeing to that you perform the work that's being done. This is a federal requirement, and you can cut and paste this. We provide a invoice template with the agreement, but if you can't find that, let us know and we'll get one to you right away. This is a sample invoice. You can use your own institutional template if you need to, but it has to have all of this information. And if you're doing subject enrollment, you have to include the subject enrollment date, the subject PID, and that kind of information, and the visit dates, so that we don't duplicate payment and so we can keep track of payment by subject. And that's why I've noted at the bottom, just above the certification, that you have to attach per subject invoice if you don't include it on this, that includes all that information on the subject. Since I think most of the people on here are clinical people, I won't go into any more detail, but if you do need any more information, have any questions, or if your institution has any questions, please contact me or Sarah Dowdy. Does anyone have any questions? All right, thank you.
All right, so definitely last but not least is going to be Michelle Feast from our access group, and I'm going to try my best to pass the mic to her with the remote so she can do her slides. If not, Michelle, then like I said, I'll do those for you.
Okay, I think, let's see.
Oh, let's see, we got to unmute Michelle.
Hello.
Okay, Michelle, we got to figure out, we're gonna mute everybody except for you.
Okay, it says I am, okay.
You got the remote. Now we just got to figure out how to mute everybody and leave you open.
I think everyone is muted with the exception of a few. And I'm wondering if.
Let's see. Let's find Michelle.
Okay, can you hear me? Well, you can't tell me, but I can see my little phone blinking, so I'm going to assume that you can, and if you can't, Jill, text me, okay? My name is Michelle Feast. I direct the Data Management Center here at UAB for the AFM trial, and I'm going to give you an overview of the data entry system, and I will, I'm aware that I have the majority of the slides in this presentation, so don't fear when you see all of these. I'm going to just skim over a large number of them, but I provided them so that you, with the presentation when it's provided, will have some references and be able to go back to them and answer any questions that you may have. Now I'm trying to Okay, good. We're in gear now. So these are the topics that I'm going to cover in the next several minutes. And again, like others, I'm happy to answer any questions once we get to the end. I'm going to begin with an overview of the system. Just briefly, it is composed of two major portions. The first is the AFM portal, and it contains both a document library and a link to your site's data entry system. The document library is just a place for the clinical team to provide for you access to study documents, reports, protocols, things of that nature, whatever they determine they want to put out there, but it provides it to you in a password protected way so that you can easily access that information. You also see here in the middle of the screen the link, which will get you to your site's electronic data entry system. Once you enter the data entry system, you hit our home page, and this essentially provides the menus that you need for entering the CRFs that were developed for this protocol. And it uses a visit schedule that follows essentially the schedule of activities and events that Dr. Kimberlin and Jill went over with you earlier in the presentation. The system provides data management tools for quality assurance and things to help us monitor and send queries. This next slide provides an overview of all of the forms that are developed for AFM, and I've broken them apart the way you see them here based on the way they're found in the system. The first large set here are those that are required, and the long list is for the group 1 patients, and there will be a subset of these that will apply for your group 2 patients. And then below you see a set of forms that they're not required. They're what we refer to as unscheduled or event-triggered forms, deviations, death report, things of that nature that only are required upon some event occurring. There are actually a couple of more forms that are group 2 forms that are going to be located on that menu. I neglected to include them in this slide, but they will be accessible for you. I'm going to talk just a bit about navigating the data entry system. Again, a lot of this detail is just for later reference, but essentially you have the links here on your main menu to get to these various sections that I've described. Once you get into the main data entry menu, there are a couple of places where you can access the same information. I pointed that out here. I do want to show you about the print blank CRFs feature, which just allows you, after selecting your patient IDs and to select the visit, to actually print the batch of forms that are associated with that specific visit. Now, the forms that you see in this example are not AFM specific. They have not been updated in the data entry system yet, so I've just got this as an example. But you essentially, once you've selected the visit, can then see all of the forms that are included there, and you can unselect them if there's something that you want to exclude for whatever reason. You simply click the print preview menu or button rather, and it will populate with that set of forms and include the PID numbers for the patient that you have selected. And then you're able to print those and use them at your clinic visit. These next couple of slides just highlight the different functions within the form. Your menu options returns you to the main menu, gives you quick access to the other menu areas. If you click on the Return to Portal button, it'll take you all the way back to that document library homepage. You also have on this screen the participant ID selection section. You have the part of the system where you're going to really drill down into the set of forms for the particular group patient identification that you have made. And we'll talk about this in a little bit more detail in a second. And then you have here the form status. So this is what's going to help you know just at a glance what the status of your forms are and how to access them. This next slide shows the form grid for patients that are enrolled in group 1. And you see here at the top the different visits that were referenced earlier, and a total of 7 for group 1. And then you see the listing of forms and the forms that are associated with each one of the visits. The locks indicate, as I mentioned, the status at each one of the visits, and they also serve as the button where you click to open up the form. This next slide shows the same information for group 2 patients with their 3-visit schedule and the associated forms for that set of visits. I'm going to get into it's going to be a bit of detail, but I think it's important to illustrate the different paths for the different cases. And so if you'll bear with me for the next few minutes or so, I'm going to talk you through new subject entry. Once you get into the data entry system and the data entry menu, you're going to simply select new subject from the screening ID drop-down menu. Once you do, your form grid is going to populate the screen below, and you will click on the lock to open the CRS1 visit status form. This is the form that we chose here in developing the system to use for you all to identify whether you're enrolling a group 1 or group 2 patient. So the very first form that you complete for every single enrolling patient will be this form, and you're going to identify their group here. Simply select it from the menu. You finish all the rest of the all the fields, and then lock the form. And once you do, it'll take you back to this form grid, and you'll see that your form is now locked. A locked form indicates that you can still open it, but you can't edit that data any further. So once you've completed this first step, then you're going to go to the Visit Forms menu. And you'll see, because we selected Group 1, that set of visits opens up, and the menu grid follows that visit schedule. So you'll then proceed to fill out the inclusion and exclusion criteria forms for this enrolling patient. I've included here a screenshot of the inclusion form. This is pretty intuitive stuff here. If you answer yes to all of these inclusion criteria, then that patient is eligible for enrollment. You'll complete and lock the entire form and then proceed to the exclusion form, which is much shorter. If all of these criteria are answered no, then the patient is eligible for enrollment. Once this form is locked, then you're going to go up on that same screen, you'll get a pop-up message that indicates and confirms their enrollment and provides what we refer to as a PID number 2. It's their enrollment ID. You'll need to record that because later on, when you come back to the data entry system, you will be required to use both the PID1 and the PID2 in order to locate that patient in the system. Once the patient is enrolled, then an automatic email notification is sent to the clinical team, to the data center, to NIH staff, and also to the enrolling site team. So we are all alerted and celebrate with you when a patient is enrolled. These are automatic as soon as that form is locked. It goes out from the system. I want to walk you through now sort of the same process with Group 2. You see here, we're going to assume that we've already completed our Visit 1 status form for this enrolling patient, and we have identified them as a Group 2 patient. So then you see here, their Group 2 visit schedule has populated. And like before, you will go and begin entry of their inclusion-exclusion forms. Here, slightly different, as has already been described, inclusion criteria. As usual, if all of these are answered affirmative, then that patient is eligible. But you will note one of the questions here is related to them being a residing household member with a Group 1 patient. And so that question is answered, The relationship is documented here. The amount of time they've been in the same household is documented, and also the PID-1 of that group 1 patient. So all of these items have to be completed and locked. And you continue to the exclusion form, same thing as before. If all or no patient is eligible, you lock this form and they're enrolled. You get the same pop-up message, document the PID-2, and you get the same automatic email notification. Okay, one more. So as you know, there are instances where group 2 patients may develop findings that are consistent with or suggestive of AFM, and that they can be offered to enroll into the group 1 group and followed accordingly. So what happens in this instance is you're going to complete any pending data entry for that patient. The form grid is whatever the status of their forms and visits are at that point in time. You'll complete all of that data entry and lock all of those forms that might be remaining for them. And then you're going to go to the unscheduled menu and you're going to complete a subject termination completion form for them. Now, it may be the case that they've completed the entire group 2 protocol, or maybe they didn't. In either case, you're going to complete this form at the conclusion of data entry for all of their visits. Once you do this, then we're back to square one with the visit CRF1. You complete the form. You're going to indicate that they're enrolling in group 1, and you're going to lock it. And then you're back to your inclusion-exclusion forms that you'll complete for them. I want to point out on your inclusion form, there is once again a place to record their informed consent date, so you'll need to key that in for them. And there's also a place to indicate that they were previously enrolled in group 2, and you'll also provide their group 2 PID-1. So this just helps us to track all of their interactions and their data and all of their activity in the protocol. Once this form is locked, like every other one, you get your pop-up message, automatic notifications are sent, and that patient is enrolled. Once a patient is enrolled, I just have a few points here regarding post-enrollment and data entry. Of course, you're going to complete your baseline assessments and enter and lock those forms. I want to note that all study forms, all visit forms should be locked at the end of a study visit. I know sometimes it takes a couple of days to get things in, but each visit has to be completed in the system and locked before the next visit will open up for you to begin data entry there. Now you certainly can, as I was showing you initially, you can print visits, the blank form. It's just for the data entry process. We guide you through the visits in such a way that there's not a chance of getting data out of order, which causes you lots of headaches if it happens. So you're going to follow along the visit schedule and the schedule of activities that you've been provided in the MOP and in the protocol, which hopefully everything you see in the data entry system models exactly. And then, of course, for each patient, as they finish the protocol, whether in part or complete, then you're going to fill out the subject termination and completion form to close out their case in the system. I want to note with this, though, that when you enter and lock those forms, it prevents any other data entry for that patient. So you want to make sure that you have everything done for them before you finalize their data entry with this form. Okay, I want to turn now to data entry form features, and I'm not going to go into a bunch of detail with this stuff because you'll have a chance to review these on your own. But just suffice it to say that there's a particular way in the system that you're going to find every form when you open it with these fields that begin to change colors as you enter valid data. And so there's color coding that will help lead you through that data entry process and make sure that the data is valid and that you know visually when you're finished. There are lots of validation rules throughout all of the forms and all the fields. These are really just to alert you to some possible problems and maybe just have you double check your data entry. They don't always mean that there's an error, but we just want to make sure that that you keyed what you meant to key. So there are some color coding for your eligibility forms or your inclusion-exclusion forms. If you document something that would suggest the patient is not eligible, those will show up with this purple fuchsia color background. It depends on what your monitor says as to what color it really is. It was purple on one of my screens and fuchsia on another one. So you get the general picture here. They're definitely clear, so you'll know. You still have to complete the entire form and lock it, but once these forms are entered and locked, you can expect that that patient would not be enrolled in the study. So all of the pop-up messages and PID2 assignments and those things would not occur. There are also skip patterns throughout the different forms based on data entry. In this particular example, some of the fields are enabled because of your answer here that some CSF studies were conducted. Same scenario below. It just allows you to block and gray out and skip various fields when the situation doesn't apply to your particular case. There are also alert warnings throughout the forms. These messages in particular are just for informational purposes. They don't prevent you from continuing with data entry or from saving or locking your form. In this particular case, it's letting you know that something you keyed has triggered a protocol deviation. And so it's letting you know to complete that form. So you would just close out the pop-up message. You can click the little X or hit the escape button on your keyboard to close out these messages. But you will find when you go back that the fields are valid and you're able to continue. On the other hand, there are some alerts that are actually, they're going to require an override request if the data that you've keyed is not valid. So these messages indicate very often a formatting issue. You keyed something, like for example, a date that's in the wrong format, or perhaps a value that's out of the specified range for that particular field. All of these fields can be saved. You just cannot lock the form until the value has either been corrected or an override request has been approved. And you see here in this particular example, there's actually the mechanism to submit that request here in the alert. And so you record the reason for your request and click this request override button in order to send that into the data center. And I'm going to talk just a tad bit more about that in a few more slides, so I'll leave it there for now. There are validation rules that prevent forms from being locked. I've mentioned this a couple of times. In this particular example, you see here a date of enrollment of 11/20 and a consent date of 11/21. Well, something doesn't add up there, obviously, and the system has validation rules that check these types of things. So you would need to correct one or the other of these in order to get it to validate. And until the field is valid, the form cannot be locked. Again, you can save the information, you can go out of the form and come back to it 2 days later if you need to, and the data will still be there. You just can't lock it until it's all correct. There are form actions in each of the forms. This is basic stuff. I'm not going to read all of it. Basically, when the form is unlocked, you can save it and you can lock it, or you can print. Once the form is locked, then you can submit a request to unlock it or to delete it in some instances. Now, here's where I want to give you just a bit more information because it goes into those administrative requests that I referenced just a second ago. So if you have a locked form that you want to unlock, you've noticed there's an error in it or whatever you need to correct, you would simply click the button in your menu to submit a request, and you get this pop-up box an on-screen request where you indicate the nature of your request and also the reason for it. You're reviewing data, you found this error, you need to correct it. So you would record that reason in the form, click the submit button, and this request is sent to the Data Coordinating Center. Once you click the submit button, you get this on-screen message just verifying that it went through. And I want to note that once these go through, we get an email notification of the request and we review them. But I want to point out that this is not in real time. So our alert system runs about every hour, and we get a whole bunch of requests from all different studies and for all different kinds of reasons, some of which are those enrollment notifications that I mentioned before. So just be aware that your response or our response to you may not be immediate. And so if you're in a situation where you really, it's urgent, you've got to move on, you might want to send us a separate email and or give us a phone call and just say, hey, I'm working in this and can you help me move it along? And we can go into the system and provide that review and approval for you in that way. Otherwise, when we get them and review them, we send out an email notification back to you. It's a manual thing. So we literally go to our email, forward you the request that we received from the alert system and verify for you that it's been approved. So that way you know when you can go back to your forms and complete them. In a number of the AFM forms, there is a feature that allows you to add multiple records for a particular content area. This specific example is for medications. I know for the specimen form, this tool is there for immunology tests and injections. And it essentially allows you to add records to accommodate however many medications, however many specimens, et cetera, that you need to report. And so on those forms, you'll see this little button that says add record. And you simply click that button and it will populate with a record or a row of fields for you to do the data entry for that particular content area. The only reason that I mention this is for what I'm about to say, because otherwise it's pretty intuitive. If you click this little button too many times and you have several rows of blank, just blank rows of fields, and you don't need all of them, you can click the remove button to get rid of them. But you can only do that little remove tool if you haven't already saved your form. If you've saved it, then it writes that blank record to the database. And at that point, it will require that same sort of delete administrative request process that I just described. So really, it's important because you'll remember that a form can't be locked if there are any yellow fields in it. Everything in the form has to be validated. And so you'll have to get rid of them, the blank rows in one way or another. Just some final notes about the data entry process and the CRFs. I wanted to point out that on a few of the CRFs, you're going to find some field-specific guidance. In particular, where there are pre-approved instances that you can enter a code for something that's unknown, that will be clearly shown on the form, like this particular example here. If you see this on the form, when you go to the data entry system to key that code, it's going to be approved. It's going to automatically validate without having to have any special permission or override or whatever. On the other hand, if you have another data point for which you do not have information and you need an unknown code, but it's not on the form like this, we're going to guide you to use this similar coding for that field, but in those cases, you will have to receive an override approval in order for that value to validate. We mentioned earlier protocol deviations and the alert messages that come up in those instances. You're going to also see on your form the places where protocol deviations will be required if something is not done. So you'll, in addition to the information on the form, you're going to get the pop-up messages. And lastly, I wanted to point out that just to be watchful of areas where there's a check all that apply, because there are multiple options that you need to sort of scan through and make sure that you've accounted for everything for that particular patient in that particular case, like this one with the various symptoms. So you simply check all of the boxes that are appropriate for that situation. Okay, just a few points about maintaining your data, and we're getting very close to the end. I want to mention that your data entry system sessions time out after about 15 minutes of inactivity, so be sure to save often, and particularly if you're prone to have people pop in and out of your work area like I am. Data is not considered to be in or submitted until the form is locked. This indicates that what's there is accurate and that it's complete. So be sure that you're monitoring that as you go through your visits. And also remember that until an entire set of visit forms are entered and locked, the next visit will not open up in the data entry system for data entry to occur. There are a lot of cross-form validation checks throughout the forms, again, just to help you keep straight what you're doing and to maintain the quality of the data as we go. Email notifications are triggered at the time of a form being locked, whether it's the enrollment, whether it's a protocol deviation notification. I believe there's a notification associated with submission of a death report. So those types of things can't happen until the form is locked. Lastly, to this same point, there are periodic data locks conducted by the data center, and those are generally done in preparation for DSMB meetings or things of that nature, meetings that are held, presentations, and of course the regular tracking reports that are produced just to monitor site activity and enrollment, and we'll look at just a couple of those at the very close. I just quickly want to touch on the unscheduled forms menu, and then we're down to the wire, wrapping this up. I mention this simply because you get to it differently than you do the main menu. There are two different ways you can get to the unscheduled forms menu here, from within an actual patient that you may have up on your screen, or from that home menu. You're going to identify your PIDs. Then you're going to select a specific form that you need from the drop-down menu. And once you do that, you'll click New Form, and you'll see that the system populates a table like you see here on the screen. To view or to amend a form is a little bit different than the main menu. There aren't the neat little locks that guide us through and tell us what the status of the forms are. Essentially, if this little amend note is more prominent, where the view is a little more grayed out, you'll know that this particular form has not been locked. You can open it and edit it, and vice versa. If this view part is more prominent and amend is grayed out, and the locked column here has a Y, that form has been completed, it's locked, and you cannot edit it. But you can open it and view it by clicking whichever button allows you into that form. Once you open the form, everything else functions just exactly as it does on the main menu. The yellow fields, validations, pop-up messages, form actions, etc. And you lock them in the exact same fashion. Okay, very last thing. So I mentioned a while ago, data monitoring. We run reports, and this is not a complete list, and certainly can be modified in whatever way is needed for this particular protocol. These are just some of the ones that we typically provide. Enrollment tracking, of course, site-specific visit completion reports, so you can kind of see where you are with particular patients. The cross-forms checks, we're looking to make sure that if you keyed something that triggers a deviation, that deviation form is actually entered in the system. And of course, some reports that will allow us to track lab shipments and receipts and things like that. We very often send queries through email. There's also a tool within the data entry system through which we can submit requests to sites and to coordinators, and we may make use of that as well. And if we do, there's a little set of slides and a manual that's associated with that process that we'll provide to guide through that. And with that whirlwind of a presentation, for me, next steps are, Susan mentioned earlier in her presentation about getting contact information for sites. The data center also needs to know some of the same information, because we need to know who will have access to the system. Certainly PIs will have accounts and have access to the document library, and setting you up in that system also provides for the email alerts and things like that to go out to you appropriately. But we also need to know who the coordinators are that will be certified, so that we can send the information to shepherd through that process. We'll provide, as was mentioned before, the slide set that you've seen here, along with that account, so that you can access what we call our beta or testing site and just play around in it and see how things work. And once that practice time is, when you're good and you're ready to move on, then we will switch you over to what we refer to as our certification mode. As has been mentioned, when all of the regulatory approvals are in place and any other trainings and those things are all done, then we will provide sites with their active production accounts so that you can begin screening and enrolling patients in the live system. That is all I have. I'm going to turn things back over to Jill and Dr. Kimberlin, and if there are any questions for me as well, I'm happy to answer those at this time. And I've turned control of the screen back over to you guys.
All right, thanks, Michelle. I'm going to go ahead and unmute everyone in case anyone has any questions for Michelle and our data entry database systems. Any questions for our EDS group? I just want to also clarify that when you guys send us the contact form for your individuals at your site, Susan Branscombe and the regulatory team will be sharing whoever you list on your contact list for EDS training or EDS system access. She'll be providing that to the biostats group for, as Michelle mentioned, access for you, creation of those accounts. So you only have to do that once. You'll provide Susan with the contact form and just denote on that form that that individual needs access to the EDS system. And then Susan will at that point provide Michelle and her group with the individuals that need that access. Any questions from anyone at this point? I do want to go back down the roll call just to make sure that we have everybody listed in participation. So I'm going to start with Stanford. Any additional people that I didn't get from Stanford? All right, I have from Rochester. Anybody additional from Rochester?
Here on the phone.
Was that Dr. Caserta?
Yeah.
Okay, I have you, Dr. Caserta. Children's Hospital, Colorado. All right, anybody that joined in from Vanderbilt? Anybody that joined in from State University of New York Health Science Center?
Me.
Who is me?
Deanna Cogswell.
Deanna. Okay, thank you, Deanna.
You're welcome.
Anybody from Rady Children's Hospital and Health Center, San Diego?
Jill, you have Sarah Hinchin and Andrea Precipata, and Dr. Moodley was on.
Okay, all right, thank you. Hospital of Sick Children, Toronto. University of South Florida. Children's Research Institution, Children's National Medical Center. Anybody?
Hi, Jill, you have Alyssa Basket here and William Saslovic from Children's National.
William, and what was the first name?
Alyssa Dastley.
Okay. All right, got it, thank you. Anybody from University of California, San Francisco?
Hey there, this is Kelsey Zorn. I'm a research coordinator from UCSF who joined.
Okay, got it. Anybody else? I had Dr. Chu also. Anybody else?
Oh, I'm Kathy from also research coordinator at UCSF.
Okay, all right. Anybody else? All right, well, I'm going to turn it back over to Dr. Kimberlin for our closeout. And I'm going to go ahead and mute everybody again so we don't get that background noise.
Well, I'm delighted we learned how to mute things on this Zoom. That turned out to be a little bit long on our part to figure it out, but we'll know obviously through the remainder of this call we knew, and then we'll have it for the next subsequent calls for this and other studies that we're all working on together. I just want to close by thanking everyone for your interest in and focused attention to this particular study. This is a big one. This is one that is receiving really national level attention. Tony Fauci at NIAID receives weekly updates directly on this particular study and the progress we're making toward bringing sites online and so forth. And I have no doubt that level of scrutiny and observation is going to continue. Now, that's a challenge for us, right? Because it's something that we obviously have to do our jobs and do them well. And I have absolutely no concern whatsoever that we're going to fall short on that. We do have the benefit, in a way, of this being a rare disease. So with that, you've heard voices now over this computer line from people here in Birmingham who are at your disposal. And as you are seeing patients and considering them for the study, as you're enrolling patients and they're becoming subjects on the study, as you're following those subjects over time, do not ever hesitate to give us a call and bounce things off of us. And likewise, we probably will be reaching out to you as we're seeing enrollments and making sure that, that things are going well and that we're providing whatever service to you that we possibly can. It's something we're all in this together on, and it's important that we do it and we do it well. Not only, for the people that are watching, but most importantly for the families and for the patients themselves. We owe it to them to learn what we're going to learn from this study and then the subsequent studies that are opening up because of this biorepository and data repository that will be available to future researchers. But none of that would happen without the skilled teams and scientists and physicians and coordinators and statisticians and everyone else that's been involved in getting us to where we are and then are taking us forward into this next period of time for this particular study. So I thank you all very, very much. Again, use us as a resource. Let us be there for you. That's what we're doing here, and we're looking forward to working with you hand in glove with this as we go forward. Thank you very much. Have a great rest of your afternoon. Yes.